Father, thank you for this day. We pray as a group that we would discern what you have to say to us to improve the lives of the Cherokee people. We thank you for the resources that you've given to us so that we can treat our people. We pray just wisdom and the ability to help our people to the best of our ability in Jesus' name. Amen. Oh. Gail, roll call, please.
Mike Dobbins.
Here.
Dora Paczkowski. Here. Keith Austin. Here. Danny Callison. Here. Julia Coates. Here. Sean Crittenden. Here. Joe Deere. Rex Jordan. Here. Johnny Kidwell. Here. Darrell Legg. Here. Wes Snowfire. Joshua Sam. Here. Mike Shambaugh. Melvina Shotpouch. E.O. Smith. Here. Canessa Teehee. Victoria Vasquez. You have a quorum.
Thank you, Gail. I assume you've had a chance to look at the minutes. I would certainly entertain a motion to approve. Yeah, all those in favor? Aye. Any opposed? Motion passes. Moving on to reports. George Valier is here today. Thank you, George. Good afternoon.
My apologies, a little hoarse from this weekend. You've got my report there. Our ER visits are fluctuating. They're stable, up, hanging around 100 patients a day. That's come up quite a bit since COVID has died down. We thought they would be higher than that by now, but they haven't. They've every now and then we'll have a day that the visits jump up to 125, 130, but they hover right around 100 a day. COVID positive cases, we're still in that age bracket of 20 to 29 years. That's they have the most positives for the month of January. That's staying steady like it has the previous months. We just got the approval to lease, some space next door in the strip mall. There, we're going to move plan is to move physical therapy over. Right now, physical therapy is in a space about 1,500 square feet, and the new space is going to be right just under 10,000 square feet. So we'll be able to expand physical therapy over there. No target date, no timeline on when we can move. We were just, that was approved by the agency. We'll work with the owner over there on getting moved in. And then finally, June, first Saturday in June, we're going to get back to having our Summer Safety Fest. We put that on to community-wide, invite the entire community out for to the lawn there on the hospital grounds. We're getting back to that. So it's an exciting time for us to get back and be part of the community again. And invite all of you up, come up and visit, bring kids, grandkids, be part of the festival. Any questions?
Questions for George? Keith?
George, you talked about taking the physical therapy to the building across the parking lot. There is a business there that does physical therapy. Is that in conjunction with that business, or is it new?
He is going to move,
okay,
and build a new space,
okay,
across town, and he's going to lease that physical therapy space to us.
Good deal. Is there a timeline on that already?
No, the only timeline is however long it takes him to get his new place built.
Okay. Well, so indefinite timeline there when it comes to building things right now. What about equipment? I know it's an equipped place. Are we keeping the equipment?
No, he's going to take his equipment with him, and we're going to get our physical therapist in and start ordering equipment when we have a little better timeline of when we can move in.
Okay, excellent. Thanks.
Anybody else for George? Wes?
Hey, George, I'm sorry I had a I don't even see you guys. I had a coughing fit for a second. I didn't catch the date of when the event was going to be.
The first weekend of June,
First week in June. Okay.
first
Perfect.
Saturday.
It's an important day. I'm like, oh man, I think we may have to miss that date, but maybe we'll send someone there. So, all right. Appreciate it, George.
Anybody else for George? Thank you, George.
Thank you.
Dr. Stephen Jones, Cherokee Nation Health Services Director.
Good afternoon. Thanks for having us. I don't have a lot to report to you today. Your report should be in your packet. But I did bring Mr. Hale with me today. He's going to be giving a little update on the, I believe it's a resolution you guys passed to have us work with Claremore Indian Hospital to see what we can do to make some improvements in the contract health world. So I'm going to let Brian come up and talk a little bit about the progress they've made up to date. We're not due to give you a formal report until September 30th, but we're about halfway through that cycle. So just wanted to kind of give you an update on some progress we've made and open it up for questions after that. So with the chair's permission, can we do that? Okay.
Welcome, Brian.
Good afternoon. Thank you all.
I think we all know you, Brian, but what's your title, position?
Brian Hale, Deputy Executive Director of External Operations for Cherokee Nation Health Services.
That's a mouthful.
Yes,
Thank
it
you.
is.
Okay.
Wanted to share with you all an update on where we are so far. We're starting off in basically assessing what the current state of purchase and referred care is at Claremore Indian Hospital. And that includes information gathering, reviewing their policies, procedures, reviewing some of their reports. Also asking the Claremore purchase and referred care staff for their insight, trying to get some input from them, as well as the leadership at Claremore Indian Hospital. And also with the help of some counsel, have spoken with some of the patients that have recent interaction with purchase and referred care at Claremore Indian Hospital. And so for background, many years ago, I believe this predates my tenure with Cherokee Nation compacted shares of the outpatient portion of purchase and referred care at Claremore. Claremore Indian Hospital provides most of the inpatient purchase and referred care for patients north of Admiral Boulevard and all the outpatient PRC in Tulsa County. Muskogee Nation, more recently, I believe in October of 2021, compacted its outpatient shares. And so it's only responsible for tribal citizens in Mays, Craig, Delaware, Nowata, Rogers, and Tulsa counties, and that's for Muskogee Creek Nation patients. So the only outpatient shares that Cherokee Nation still has at Claremore Indian Hospital would be for what we call non-Indigenous patients that reside within the Cherokee Nation jurisdiction. And so non-Indigenous refers to American Indian or Alaska Native patients other than Cherokees that reside within the reservation. And so that's really the only outpatient component that Cherokee Nation still has at Claremore Indian Hospital is purchased and referred care. I think it's important to just have that out there as background for you all. And so some of our findings so far are that, and I think this is pretty obvious to everyone already, there's limited funding for Claremore PRC, which leads to deferred or denial of care. Claremore's PRC budget is $6.1 million annually. That's the most recent number. And this is apportioned so that they have $117,000 per week to allocate. And they use a priority system. And so far, right now, they're approving priority 1 and priority 2, which is pretty easy to understand. That's all life and limb-threatening, or priority 2 would be quality of life. They are able to consider some priority 3, which is going to be elective or preventive procedures, and they do not consider any priority 4, which is more cosmetic and elective in nature. So just to understand what the numbers look like, the 2021 IHS user population report reflects 119,000 users within the Claremore Indian Hospital system. And that user population report is based on residents, not utilization. So that's how many are attributed to the Claremore service unit. 63% of that user population is Cherokee Nation. And in fiscal year 2022, Claremore PRC processed over 16,000 referrals, and they're projecting 18,000 referrals for fiscal year 2023. To put it in comparison, Cherokee Nation Health Services processes on average 12,000 referrals per month. It appears that Claremore's referrals have about a 40 to 45% approval rate with a 55 to 60% denial or deferral rate. And after a denial or a deferral, the patient has two separate levels that they can appeal that to. Besides the funding, some of the other fundings that we found related to response time, adequacy of funding, accessibility and communication, and the appeals process. Also ER call-ins, fiscal intermediary payments, and that's because Claremore IHS uses a fiscal intermediary to pay its vendors, whereas Cherokee Nation pays purchase orders directly. The other significant finding that we found was related to PRC staffing. Claremore has recently added additional staff, almost doubling the number of some of the staff that it has working on PRC. So I want to give Claremore PRC credit. They've done a lot of work to improve the situation, especially in regard to communication with their patients. They have adopted a new system that notifies patients of the final status of those referrals. That helps them with the appeal process getting done a little faster. They've also piloted a program to include nurse care managers within the PRC system, and that's garnered a lot of positive feedback from the patients. We think much of that positive feedback is due to those nurse care managers actually being on site at Claremore. Communication barriers with the vendors has been a focus of increased effort by Claremore PRC, and I think they've made some strides there. We are currently putting together our first draft for consideration by Chief Hoskin, and going forward, we'll continue to do this work with Claremore PRC and their hospital's leadership to improve that experience for everyone. We'll continue gathering information and engaging in performance improvement projects for both teams. And I'm happy to answer any questions that you might have on our project so far.
Question for Brian. Danny?
And thank you for being here today. So when we're, say, an emergency room on the weekend, okay, are we working on, and George and I have visited about this before, cutting down the process by you know, if it's a broken bone or something that needs to be treated by the point of not going, you know, by the time we go through them and the paperwork before they get it to us, you know, sometimes it's 3, 4, 5 days. Have we worked on maybe cutting that down to where it can be? I know we've had a couple of pediatric orthopedists, like broken arms and dislocations and stuff in my neck of the woods that we've needed to talk about. So are we working on maybe shortening that time length to where that they're not going to cover it, that we cover it, and that we push them on?
So there's been some biweekly reporting in identifying those patients. We've actually helped, I want to say, 25% of the folks that were either initially denied or deferred care. So I think that the coordination that we've got between Claremore's PRC and Cherokee Nation's PRC is helping with some of those ER call-ins that maybe get kind of lost in between the two systems. And I think that Claremore PRC has also put a lot of effort on improving the entire process all around for the ER call-ins.
Thank you.
Mhm.
Sean?
Yeah. Mr. Hill, the contract health dollars there at Claremore, are they competing with non-Cherokee?
They have the
Such as-
same amount of dollars for everybody they take care of. So I think the
As
short answer
opposed
to your
to-
question is yes.
As opposed to Cherokee Nation Health System, right? Now, our contract health dollars, Cherokee people, right?
In some instances, yes. In some instances, it takes care of everybody within that contract health service administrative area. So it kind of depends on which category of contract health we're talking about. But at Claremore Indian Hospital, their funding is from IHS, so it's for everybody in their user population.
All right, clear this up for me while we're talking. I remember a tribe pulled their shares, and I'll just have to admit, I'm not 100% on what that actually means. I know enough just to kind of be dangerous, as they say. But just here briefly, pooled their shares, then we have shares. Will you explain that kind of? Just kind of what that might mean?
So the shares are based on the user population typically that a tribe has within that service area. And it's how much of that operation that IHS continues to operate is represented by that size of the population. And so Cherokee Nation is, has 75% of the chairs, I believe, at Claremore Indian Hospital because we have the predominant population for that area. So when a tribe pulls its shares, what it's saying is it's going to be responsible for operating that portion of the program that it takes the funding away from for that IHS program.
So the tribes that pool their shares.
They want to administer it on their own. So they're going to take those dollars away from the Indian Health Service and say they're going to operate that portion of that program on their own.
And that would affect services that tribe can get at Claremore? If they pool it?
That's a decision made by IHS. There is the potential for that to be the case. Typically, I don't believe IHS adheres to that, though. I think IHS continues to take care of those folks when they come into the hospital. But there are some services, specifically when it goes into contract health, that IHS would then not be responsible for, but they would continue to provide direct care.
Interesting. But thank you, Mr. Hill. Thank you, Chair.
Brian, you mentioned the term non-indigenous. Could you kind of define that again for me?
So it is a American Indian or Alaska Native that is not a citizen of Cherokee Nation, but lives within the Cherokee Nation reservation.
So
And
we're
they
calling
refer
them
to it as
non-indigenous?
non-indigenous, yes.
That's the first time I've heard us describe other natives as non-indigenous.
It is a term I was unfamiliar with as well.
Okay. Danny?
Pardon me again. So when we talk, so if you get, because all the referrals basically from about halfway between Peggs and Locust Grove to the north and to the west goes through Claremore because of the IHS facility and the way it's split. All right, so what does Claremore cover and what do they not cover?
So they're going to take care of those non-indigenous folks that live within the Cherokee Nation jurisdiction, and they're going to take, which means basically anybody besides a Cherokee Nation citizen within that area. And as far as that area that you're talking about, I believe that's going to be it as far as the outpatient goes.
So how do people get, do they not have to be denied through them before they get to us? Is that not a process to where we could cut out of maybe where, I mean, that's a time frame. I mean, if by the time you apply, then you get denied, then you get a letter, you get a call, then you have to reapply. I mean, it's kind of confusing to those folks that live up at that area. Is there any way we can simplify that?
If they start their care with Cherokee Nation, it doesn't have to go through that entire process, is my understanding, but that may be an opportunity for improvement for us to look at.
Thank you.
Go ahead, Wes.
Yeah, I think just to kind of speak on Callison's point of view there, I have it on our side too over here where we have Cherokee Nation citizens going for a referral and they have to go through the process, I guess, and it's defined by the federal government, I think, in a process of denial so many times before they get it approved, just depending on the scope of the emergency. And I do think that's a great idea as far as offering a better streamline. I think the PRCA is starting to be able to look at doing that on these emergency situations over the weekend, to be able to try to say, hey, a Cherokee Nation citizen walks into the ER over at Claremore Indian Hospital, there's a notification sent to us to allow us to approve that referral, so that way there's not a process being backed up. I guess, is that kind of what we were trying to get to on that
The
side of
ER
things?
call-ins, the ER call-ins are going to be in reference to someone going kind of outside either Claremore or Hastings to another ER. Think someone who, maybe they have a, multi-system trauma and they're taken to Tulsa.
Right.
That's the kind of ER calling that we're talking about. Those patients need to, within 72 hours, notify their respective contract health department.
Okay. Yeah, all right, perfect. I've had one specific call that was dealing with that, and it's been probably a year and a half ago where we were trying to get a referral approved for that, and I think you guys, staff, I know, was on with kind of everybody at that point, so appreciate you doing that, and I'm glad that y'all are looking in to try to get that more streamlined to have it processed there, so appreciate it. Thank you.
Quick follow-up, I'm in the visiting mood, I guess, but this has been talked about a lot, but to remind me again, why, now it may be a IHS thing or something other than our decision, why can't we use the word pending instead of denial? Just probably easy answer.
I think that is IHS nomenclature. You know, they have traditionally used denial or deferral. I think in some instances, though, they use the term pending, but I think Cherokee Nation PRC uses the term pending some.
Okay, all right. Good, thank you.
Hold on. Well, let's see. Go ahead, Wes, and then Keith.
Kind of like Crandon over here, when he said something, it sparked something else in my mind to ask, because it is that referral aspect of it. Is there any way we can look at, I know it's going to be on the federal side, so you guys would have definitely the say-so to kind of push it back to IHS and say, if we were to put in kind of an automated system to where we know someone's asking for a referral, and then there's going to be a denial, if there's an automatic referral, just go right back into it, so that way some citizens, I don't know, I see they get frustrated, they get confused, or I'll get a phone call and be like, I've been denied, I don't know what to do, and they just want to give up. And I think in order to prevent that confusion, if we were able to start a process to where, and like I said, I don't know if we can, or maybe we can start advocating for that process, which is once they get a denial, that denial letter will say it's already been resubmitted for a reapply for another approval. If you do not want this to happen, please send us a letter to prevent us from moving forward for another application, so that way it automatically comes back without having to reapply every single time.
I think that's a possible solution for us to look at, and also I think IHS is looking at reducing the levels of denial before you can just go to Cherokee Nation.
Yeah, okay, perfect, awesome, appreciate it. Appreciate it, Chair.
Keith?
Brian, just trying to clarify some things. I think maybe it's in my mind, maybe I've got it wrong, or maybe just not quite the right things have been said in the room. But when a patient goes to, when a patient who lives on the north end goes to Veneta, Jay, Nowata, Oshaleta, and they, well, frankly, any place in the Cherokee Nation healthcare system, and they require contract health, that still has to go through Claremore Indian before it's funded, if it's contract health outside of our system, correct?
That is my understanding.
Okay.
Yes.
So it's still, yeah, regardless of where they go, if they show up at right across town here, it goes to Claremore Indian for funding, and it can be denied before then we can find before then we can fund it.
Depending on their residence, there is the potential for that.
Right, so it's a residency issue, not where they show up
Correct.
for care issue, because the funding still goes through them. That defined line, Danny talked about it being somewhere between Rose and Locust Grove. I've always heard it referred to 412, but I doubt that's the defined line. That's probably just a common point. Where is that defined line?
The one that I'm familiar with is the kind of that northern one, which is Admiral Boulevard. I'm not sure which one it is along 412.
So does it go all the way to Arkansas? Everything north?
I believe so.
We can get you a map.
Okay.
Let's get you a map.
Because it depends on if you're looking at inpatient or outpatient. The easiest thing is going to be for us to get you a map to use as reference.
I mean, I don't think too much about what goes on in say, West Salem Springs, because that's not where most of my calls come from. But I know I have been involved in one just recently for somebody who lived in West Salem Springs. So I just want to clarify some things. Thanks.
Joe?
Hey, Brian, you're talking about the shares in Claremore. 6 and Peoria, the Indian Healthcare, do we have shares in it as well, even though it's on the Creek Nation side? Because I know we used to have WIC in there.
Not to my knowledge, no.
Okay.
I can try to find out, but I'm not aware of that.
Okay, because I didn't know if it was vice versa going the other way as well. Is the WIC office still over there?
Where?
It's 6 and Peoria?
Yes.
It is still over there? Okay. So as far as you know, we don't have any shares in that?
No.
Okay. That's all I needed. Thank you.
Sean?
follow up. I want to end on this note, because Mr. Carey and all the staff, I mean, they are good to work with. And to end my questions in this, in our book, it says referral, approval rate, contract health, big old 95%. That's a lot. So tell the staff and everybody how much we appreciate them being available on the phone calls and doing everything in their power to help these people that sometimes are in binding situations. So
We
thank
will.
you, guys. Thank you a whole lot.
Thank you.
Brian, you mentioned that Chief Hoskins is going to put forth a first draft. Is that a plan going forward? When was that date that he anticipates putting that out?
We're supposed to have a report, I believe, September 30th of 2023. We're supposed to have our final report.
Okay. Okay. Okay.
Thank
Any
you
other
all.
Rex?
So if I understand this right, someone from OK that's kind of out of the area that goes to Claremore, they go up there, they get turned down, then Cherokee Nation can take care of them. Is that correct?
Depending on their citizenship and what the need is, yes.
Okay, they're citizens, Cherokee
Okay.
Nation citizens. But because of the dividing lines that are set up, they have to use Claremore system. So if they get turned down there, then Cherokee Nation can pick it up
In most instances, yes.
in most instances.
Yes. If that is something that we would approve, then yes.
I'm sorry?
If it is a procedure or a consult that Cherokee Nation would approve through Contract Health, then yes, we could take care of it.
Okay.
Mike?
I think a lot of confusion comes from when we farm people out to go other places, and then we don't pay for it after sending them. They don't understand, why, if we send them out, why we're not going to pay. And then the appeal process is at least 2 or 3 times appeal before they can even come back to us through IHS. Is that correct? I mean, that's been my experience, is that they need to appeal it or be turned down at least 2 or 3 times before they can even be considered.
It's
By us.
it's 2 denials right now. And
Okay.
what they're looking at doing is saying that first decision is 1 denial, which is, and then the second appeal would be the second denial. That first appeal, that decision would be the second denial, and then it could go to Cherokee Nation, if that
Okay.
makes sense.
So really
So the first
paper,
no-
1 paper, and then 1 paper.
Correct.
Okay, all right. And that would make it easy for us because, we have to tell them to do it again. And that's hard for us to do, that's hard for people to do sometimes, is to keep getting told no. It's hard for some families to cope with that, and they don't want to do it again. So that would be probably a good way to maybe help that out. So, but your money, Indian Health Services money is more contingent upon if you're going to pay, if you have it there to pay. I mean, because once you run out for
Correct.
that month. Okay, and does it vary per month, how much money you get per month, or are you pretty much locked in the same thing, pretty close?
They are pretty much locked into the same amount from month to month.
Would you say that now, or want to do it off camera? I mean, I don't care. I understand either way, but I'll talk to you afterwards.
Okay.
All right, thanks.
Anything else for Brian? Okay, I think Dr. Jones has a few
Few more things. So
remarks.
I just want to reiterate that Brian he's the project manager on this. This was a resolution you guys put forward for us to look into it, find the shortcomings, make a report. Our report's not due till September 30th, but we wanted to give you an update of some of the progress we made, so you realize this is a long process. It's not something we're going to throw together in 30 days. So a lot of the questions you're asking are things that are coming to the surface that are going to need to be addressed. We don't have solutions for all this yet. We're in that fact-finding, kind of put all of it together, and then start working towards solutions. So just want to, I want to kill the messenger here, so I asked him to come and just give an update so you would know kind of where we're at with it, that we are working on it, and we're working through some issues. There's a lot of nomenclature or terminology that we speak differently than IHS speaks, and kind of what you're saying, pending and deferral and denial, and trying to get all that down so everybody's talking the same language. For us in the medical and healthcare world, inpatient, outpatient, that's something you got to kind of get your mind wrapped around too. If it's in the hospital and you're staying in the hospital, those funds are still staying there at Claremore, but we've compacted some of the outpatient funding. So there's that definition, and how that person gets picked up is a lot about what treatment they're receiving. So there's a lot of confusion, and a lot, as you guys have experienced, and we're trying to kind of clear that up, and it'll be given to you in a report when that time comes. But I wanted you to know that we're working through it. We're working through it with Claremore and trying to come up with some solutions to make it easier on our citizens. So.
Well, it's kind of like our HR, we've dealt with some issues there too. I mean, you communicating with us is a big deal, especially, when you're addressing those problems that we're dealing with, and you're telling us how you're addressing them and that you're aware of it. Change has to start somewhere.
Right.
And we understand that. I mean, but we also we want to see that effort that you're doing. I mean, because that just reinforces our belief in you, and I think it's important that you tell us what you're doing like that. So, we do understand, and we do understand it's got to start somewhere, and it'll start small and grow. But I commend you on starting this process out, because it's a long time coming. But it's got to start sometime. So,
Yeah.
Thank you.
And it's a very deep dive. We're
Yeah.
not just touching the surface. We're trying to get to the very root of what the problems are and how we can work together to get them resolved. We don't want our patients caught in the middle, and that's what's happening a lot of times. So, and you guys get the brunt of that. So we're trying to figure out how we can facilitate that a little better.
Johnny?
Dr. Jones, thank you for being here today. A little off topic, but I do want to thank you for being available the last few weeks, and whenever I needed some help with I don't know if many people know this, my mom's been in and out of the hospital last 3 weeks. And Doc Jones, I appreciate you answering the phone. I'm sorry to bug you during your opioid recertification training.
Okay.
But pass that along to Dr. Montgomery as well.
Yeah.
The input that he provided the other day, just a few days ago, was right on point and helped us out immensely over in St. Francis. So I truly appreciate you guys.
Great.
Thank you.
Thank you. I'm glad we could help.
Any other questions? Danny?
Dr. Jones, this is a note of thank you. If you've been by the AMO Clinic, we've got a new awning that when it's pouring down rain, which it has the last couple of weeks quite a bit, the handicapped folks can pull under there and get out of their car and stay dry all the way in. And I want to thank you for that. I appreciate that, sir.
You're welcome. I hear they're going to put your name on it. All right.
Before I let you go, just briefly tell the council the recent media reports about the insulin prices going down. Does that impact our bottom line, or one way or the other, does it?
I'm sure if the prices continue to drop, it will help us. We do purchase our insulin through the GSA or government contracts, so we are not subject to all the retail fluctuations that maybe the retail market's subject to. I do know that, I think it was Eli Lilly was the first company that, I think there's 3 main companies that produce insulin, and Eli Lilly was one of the first ones to say, we're going to drop our price and fix it. I think the other 2 companies will probably follow suit. I don't know how much that fixed price is going to impact difference from what we pay GSA. I don't have that knowledge right off the top of my head, but I do know our pricing has always been pretty stable through a government contract. So we don't have that real up and down pricing that affects a lot of retail sector. Where it does affect us is when the pricing goes way up because of supplies. It can affect the supply chain, and that's part that we're glad to see that everybody's going to get on the same page about.
Very good. Okay, thank you, Dr. Jones.
All right, thank you.
Lisa? Ms. Lisa Pivick, Cherokee Nation Public Health.
Get all my things in order up here. Good afternoon. It's good to see all of you again. It's spring break, but it doesn't feel quite like spring today, does it? Hopefully we'll get some warmer weather coming soon. You do have my report. There's a couple of things I want to highlight on the report, and then I'm going to be happy to take any questions. A few updates of things that we're working on. Throughout the last year, so you've seen the initiative Working Together on your report and probably wondered what in the world that is. This month's report has a little more description about the Working Together initiative, and I wanted to give you a little more update because it's taking more shape and we're developing more solid goals and objectives around it. As you look through there, you see that the three main things that we wanted to do is create a shared vision for Cherokee Wellness, and when we say Cherokee Wellness, we're not just talking about your physical health, but we're talking about overall wellness in general, housing, transportation, jobs, education, everything, mental health, all of that. And then create a wellness framework reflective of the social and cultural determinants of health, which we have accomplished the first two. And now we're identifying indicators to determine how wellness can actually be measured so that we can actually have a report of how we at Cherokee Nation are collectively working together for overall wellness of our citizens in every division. And I told you earlier that we had involved education and the environmental programs and commerce to this date. And as of last week, we added the environmental services, roads and infrastructure and transportation, human services, grants management and development, information systems, self-governance office, and a representative from the chief of staff's office. And in that time of work together, we are started to identify, sit and have individual discussions with each division and figure out how we can collectively work together to make an impact, a collective impact on our citizens. We find out when we sit down together that we all touch the citizens in different ways in different places. And how do we do that more collectively? How do we harness our resources, offer our services that are more comprehensive together, and then work more together on projects, such as how can three of us get together and write a comprehensive grant application that meets the needs of all three of us as divisions, and really work in a manner that starts to strengthen who we are more together collectively. And it's been very positive. This last week in reviewing those hard data indicators, we've found that lots of people collect lots of information, and there's lots of ways that we can look at collectively and say, how well are we doing? And I want to say that each division that's worked with this has been very receptive, and we look at ourselves in public health as a service provider to the other divisions, and our role is how do we be that facilitator to find out how we do this job better. So as the months go by, you're going to start to see more information about this. I think I mentioned earlier, this is one of Deputy Chief's projects that he's been working on with us for the last year, and has proven to be quite successful. It is a long and hard project as well. It is, when you talk about all the work that Cherokee Nation does collectively, that's a lot of work and a lot of people. So we have people on this team, some people who've been at Cherokee Nation for 30-plus years, and about the other half of the team, people who haven't been here near as long. So we have historical knowledge, historical information, then we have new ideas, new technology ideas, and looking at subjects that we can make an impact on. So I wanted to share that with you because you will be hearing more, and you will be seeing a copy or an actual visual presentation of what this is. We've developed this concept in a visual form, and it's going to start moving forward over the next year. And I'm really happy to report on it because I feel like that of many of the things that I do on a daily basis, and I know that counterparts across every other division are working just as hard on those things, and I think there's ways we can, without creating more work, support one another better. So I wanted to report on that. The next thing I wanted to report on is that the National Association of City County Health Officials, you see that on my report monthly that I serve as on the board of directors. We have 2 in-person meetings a year, and my role on that is to look at what the National Association of City County Health Officials does. So it works directly with local health departments. So in Oklahoma, for instance, we have what's called a mixed system. So the Oklahoma State Department of Health has jurisdiction over all the county health departments with the exception of Oklahoma County and Tulsa County. So they are independent health departments, local health departments, that get their funding in different mechanisms in different ways, and they don't report directly to the state. They're not under the purview of the State Department of Health. So in those meetings, those representatives from those health departments are available and there, and we have started working on a project of how Cherokee Nation Public Health and the two health departments can develop some formal relationships to support one another and support public health within the Cherokee Nation and beyond. I do want to say that on that board, there are representatives as small as very small counties in Missouri, and as large as the health department that serves Dallas, health department that serves Austin, Seattle, Tacoma area. And so it's a very diverse board, but what is in common that I heard at this last in-person meeting is that they're all struggling in some sort with support for public health. And I realized at that meeting, and I told my staff this morning about how lucky we are, how fortunate we are at Cherokee Nation to have the support for not only our health system, but our public health system as well. Not everyone across the country experiences that great support, and we are very lucky and grateful to Cherokee Nation administration and to you as the council for that support. The last thing I want to mention is you see all the activities on our report. There's a variety of them. Lots of things kick off in the spring, and we have a lot of specific things going right now. We are also heavily focused on performance management, so bear with us as we go through every project or program that we have and do what we call a performance management and quality improvement assessment to see how we can offer those services better, how we might coordinate with other divisions and provide better services and create those improvement plans over the next year to year and a half. So we have a lot of work going on, and you can look through and ask me about any of the specific services, and I'm happy to answer any questions.
Questions for Lisa? See none. Is Dr. Gann on the staff at Public Health?
He is the medical director for public health.
Well, we're missing him.
Okay.
He was our COVID guru, I guess.
Yes.
So maybe extend an invitation for him to come next month and kind of tell us what's going on in his corner of the world. Appreciate it. Any more questions for Lisa? Thank you, Lisa. Ooh. I see no old business pending or new business pending. There's one announcement there. Our next scheduled meeting is April 10th at 1 o'clock. Any other announcements? Need one more motion. Second. All those